Thanks for inviting me to speak at the Petal program. We are one of the sites as well, so I'm quite excited about this. So I'm consultant psychiatrist in intellectual disability only until this week, and from next week I'll be working with adult with ASD and ADHD. So my identity is slightly changing. I'm director for Research Forward Trust, and Afia mentioned about the centers. We set up this center about 4 years ago. And the talk I'm doing, the DSD-CST is one of our earlier project as part of the centers. We use the Center for Autism, Neurodevelopmental Disorders and Intellectual Disability. And our focus has been actually looking at what is needed in frontline services, what innovations, new ways of working we can bring to frontline services, and then evaluate those innovations. And I think that, like I said, the DSD-CST has been part of that development, and it's one of the first project that we did. So it is a tool, but I suggest that not to look at it just as a tool, but it is kind of a catalyst to bring about a particular response from the system or a particular set of interventions for systems. So kind of from evaluation point of view, if one has to actually look at, it is more as a system level intervention that brings about changes in the way we respond to challenging behavior. So it is not a therapeutic tool. It's not a therapy program or anything like that, but it will work in synergy with some of those things. Um, so let's see if the slides move. Okay. So we all know how all these things started when we talk about challenging behavior, etc. So it all, I mean, it's not, Winterborn is not the first thing, isn't it, that had happened, and it is not the last thing that had happened as well. So there is a long history of some of the difficulties people with intellectual disability and autistic adults or children actually faced over the years, over the decades, in terms of institutional care and abuse. And it's not that abuse or the problems are just in hospitals. They are actually part of a lot of other institutions as well. But for the purpose of today, we are talking about the hospital care. And there have been a number of inquiries, and as part of that, with the Winterborn view review, there was some commitment to transform how we provide services for people with intellectual disability and autistic people in the community, those who are presenting with challenging behavior. And the 2-3 key directives that have come out of that: there is a care and treatment review, there is stopping overuse of medications in people with intellectual disability, and then separately we have a leader program as well. So idea was behind this is to strengthen the patient support through the community services and reducing the need to rely upon inpatient care. It's kind of like easy said, difficult to do sort of things. The association of inpatient care and kind of, what happened in Winterborn View, et cetera, and kind of like, the focus on reducing admission might be correct. I mean, I think, we do need to reduce the reliance on hospitals, and there were examples of people being stuck in hospital for 30 years or so, et cetera, quite tragic examples. So then the CTR came, so which is the care and treatment review. The policy and guidelines came out, where again the focus had been, well, we want to prevent unnecessary patient admissions to hospital. We want to avoid inappropriately long hospital stays, and the requirement to keep a local database. And this is where the DSD-CST has come from. So the commissioners asked, okay, well, we all should know who are the people who are at risk of admission, and they wanted to know, and they wanted to keep the database. So how do you go about that? So that's something kind of like, we wanted to actually think about in terms of solving that actually problem or issue. So the ask was that there was a need to keep a database. Um, and I had worked in London. I had just moved to Northwest as well, and I was aware that there was wide variation in terms of how people were actually looking at who is at risk. There was wide variation in what the response used to be from services. So, okay, the names were get put on the database, but nothing else was changing as well. um, the CTR guidelines were there. They did say that, okay, well, if these things are there, you should be considering them as high risk of admission, but they were not objective or reliable way of measuring that. So people were basically doing their own things. And then there was no agreed response framework as well, as to what happens to this population. So what we wanted to do, so we wanted to actually look at this population of people with intellectual disability and autistic people who are presenting with challenging behavior. And kind of, we want to ensure that everyone who is accessing community services should have good outcomes. And this is where we wanted to bring the population health principle, population health management principles to that. So we can't have same offer to everyone, because that's not going to lead to equity of outcome. So if we don't want to actually, or if you want to ensure that equity of outcome, then we have to find a way of actually understanding those differing needs of the population. And this is where the whole concept of stratifying the needs come into place, that you look at the population, you stratify based on actually certain characteristics and what that response should be. So we wanted to do a bit more than just keeping a database. We wanted a system that will tell us, as a community learning disability team, but as actually to wider agencies that are involved in the care, as to what our response should be. Um, so we started thinking about, okay, well, how do we go about that? And this is where um, we thought, okay, well, let's look at actually, what happens in the population health management. On acute health sectors, they use quite a lot of those things. In public health, they use quite a lot of those strategies. How do we transfer those to our population? So we wanted to take an approach similar to this, not like this, but something similar to this, where we actually start looking at, here we are looking at admission avoidance. Here we are looking at managing people with challenging behavior in the community. It's not that everyone can be managed. There will be a need to admit someone into a hospital, but how do we actually have different levels? How do we stratify our population, let's say, into low, medium, high risk of admission? And are we then able to create an offer specific to those levels that will then mitigate against those risks? So that's what we wanted to achieve. We wanted to take a population health management approach. We wanted to develop a tool that will proactively identify people with intellectual disability that were at increased risk of admission, hospital admission. So that's the proactive identification was very important. We wanted to bring objectivity and standardization in a way we identified those. We wanted to take a more relative risk approach, in the sense the risk in relation to the rest of the population, population of those with intellectual disability, not general population. And we also wanted to develop a offer or response based on that relative risk of admission. And when I say relative risk of admission, I think kind of everyone with learning disability is at a higher risk compared to general population. It's within that population how we are actually changing or defining or developing that. It started as a sequin, actually. So we didn't set out to set up a research project or anything like that. It was a ask from our commissioners who were desperate. They were saying, oh, can we do something about it? And then we came together collectively and started thinking about a practical solution to this problem. Um, so we have been through a long process. It's an ongoing process in a way, actually, kind of Afi, and we were still thinking of doing kind of building some research projects on this going forward, or evaluation projects. So we started with what the CTR guidelines were. So they had actually identified the variables in the CTR guidelines of 2015, that, okay, well, these are the criteria that we should be looking at. We felt that they were not just enough. There was need to do a bit more and consider a bit more. So we had focused group of multi-professionals, and then we looked at those variables, and we decided to kind of rate those variables for potential significance, because some had more impact on likelihood of admission than others. We then actually started looking at weighted scores for those. And then again, we had focus group to discuss the weighted scores and then the cutoff points based on the low, medium, high risk. We used case scenarios, etc., case vignettes to actually look at how the scoring will work and how the cutoff will work. Obviously, at that time, we didn't do any factor analysis or anything of those things. We were just trying to find a practical solutions. And out of that, this dynamic um, 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 a support tool database for community support tool came about, DSD-CST came about. We piloted that in a couple of teams with short, kind of like small sample sizes. Based on those feedbacks, then we developed our training material. We started it rolling out in our trust, and then we started looking at some of the other aspects of the tool, like clinical utility, acceptability, inter-rater reliability, face validity, etc., etc. Um, uh, and I think kind of what it was. I mean, I think, I wasn't that bothered about all those various psychometric properties, because what we immediately started seeing is the impact that it was having in terms of how we were delivering our services and the outcomes that it was leading to. And I'll come to that in a minute. So the tool has been then was taken over by Operational Delivery Network and was upscaled to the Northwest region. But since then, it has been used in a number of other areas and other services as well. And it's part of the NHS England good practice guidelines. So what does the tool do? And I'll show the tool at the end because it's a Word copy. I didn't know how to put the Word document into my PowerPoint slide, so excuse me for that. But it has 12 items, 12 scored items, and then there are 4-5 other items that are more for information rather than for scoring. And it basically, based on the scores, it actually stratifies into 3 groups, red, amber, green. So it's a RAG rating, basically, that's you get at the end. Reds are those who are at imminent or immediate risk of admission. Ambers who are facing significant deterioration in the community. So there might actually lead to red if we don't provide the intervention. We do have a kind of a in-between category of deep amber. So the commissioner started asking, oh, we want to know about the ambers as well, and deep ambers who are actually more towards the red category. That's more of a clinical judgment. And then green, who are reasonably stable, although these individuals are still quite complex and do hold significant risk by nature of being open to CLDTs and CAPs. As part of the development, as the DSD-CST became quite successful and embedded in adult CLDTs, we adapted a version of it for use in CAMS learning disability services as well. Hence the mention of CAMS. So it's a slightly different version, adapted version for CAMS. So based on the ratings, there is a offer or kind of what the services should be doing. So green is like, you're continuing what you are doing, you're continuing with the risk management plan. It still needs to be person centered. It still needs to have all the components as CLDTs will provide. It will be standard care rather than CPA, where the CPAs are available. Not all the services have CPAs. Ambers, a person who is facing significant deterioration in the community. So there is an increased risk of admission, obviously. There is a deterioration in mental health or escalation in challenging behavior. So in those situations, we do inform the intensive support services. They don't get involved, but they are aware of what's been going on. We actually start a CPA. So there is allocated care coordinator for that, then care plan, risk assessment plan, everything gets updated. And then we have a multidisciplinary formulation based intervention. We do inform commissioners of ambers, so they have now started asking us for data on ambers as well. And then in the rates, so who are at immediate risk of admission, etc. Obviously, it leads to CTR. So it's communicated to. Sorry, I went ahead. It gets communicated to commissioners for CTR or CTR. We have admission avoidance meeting, intensive support service gets involved. We do liaise with our inpatient services, so they are aware of it. They get involved in our community CTR processes as well, so as part of the gatekeeping. So basically, we try to do everything that is possible to stop the person from getting admitted. We did some kind of, evaluation around DSD further down the line. Like I said, it started as a sick win. So some of the looking at the inter-rater reliability, etc., came a bit later. But we did look at actually clinical utility, how useful people find it. Do people feel that actually what is coming out of DSD-CST is kind of like, congruent to their clinical judgment. We did look at the inter-rater reliability, etc., etc. But interestingly, kind of like what it also showed that our admission rates went down significantly. So there was marked reduction in use of inpatient care in Cheshire and Wirral. Within first 2 years, our admissions went down by around 80%. And once it was rolled out in the Northwest region, the Northwest region figures went down by around 72%. So, so what we saw that there was marked reduction in the new admissions that we're going to. I mean, Northwest has a more longitudinal chronic problem of long stay. There are significant people in inpatient services who have been there historically. And I think, as part of the Transforming Care program, they are a little bit behind. But the new admissions wise, that was quite a bit of success. Now, I wouldn't say that that's because of the DSD-CST, because around at the same time, we developed the intensive support service function. And part of the intensive support service function, we decided that actually, rather than having a separate team, we will incorporate intensive support services within existing CLDTs. We felt that's better for joint working. It just gives that community learning disability teams that additional resource to respond to crisis, to urgent situation, etc., etc. So almost our ISS are trying to do things that were not possible in terms of that providing intensive input. So we developed that around at the same time in parallel. But what actually DSD-CST did is that it provided a language for everyone to actually do certain things, and everyone knew what they should be doing, etc., etc. So overall, we had quite a positive results locally and regionally. So what does DSD-CST do? It's standardization of the process of identifying those at risk of admission. It does help to kind of think about how the resources should be allocated in terms of managing the risk. It provides the data as well, longitudinal data in terms of numbers, etc., etc. etc. It does support decision making, although it is reliant on clinical judgment, so it doesn't dictate it. It is a common language. I think our commissioners have got quite used to this as well, and hopefully, I think it leads to equity of outcomes by kind of stratifying the populations based on their risk or needs. It is, I think, generating good population level data for us. Um, there is information on the tool on our website, which is a Candid website, candid.nhs.uk. I have put the link in here so that it has both the versions of the tool in Word format, the adult version and CAMS version. There are training videos and there is training material there actually. So it tells you, shows you how to score with case examples, etc., etc. So all the material, including standard operating procedures, you'll be able to find by clicking on that link. So what else is happening? So we learned from that. That was our initial exercise, but we actually were quite heartened by the outcomes that we actually got with DSD-CST. So since then, we have now developed a decision support tool around physical health. This is about LEADER program. So this is actually proactively identify those who are at risk of premature mortality. So we are going through now various sort of validation exercises, etc., etc. We have rolled it out. We rolled it out in COVID period, and again, it has put us in good state. We have developed a complex need escalation and support tool. So this is a CAMS version. This is not CAMS LD version. This is a CAMS version, but it incorporates all the DSD-CST factors as well. So this is for any a child or young person who is at risk of admission. That tool is used at the provider collaborative in Gateway for gateways to prevent admission to tier 4 camp services. We also have universal need-based resource allocation a tool. This is to look at inpatient services and resource allocation in that. And we are in the process of actually looking at SEN population within the local authority. So we are halfway through developing that. And I think that's it. This is a whistle stop tour of DSD-CST. Um, so happy to take any questions. What I might do, if we have a couple of minutes, I will try to show the tool. Are we okay for that, Afia?
Yeah, yeah, that's fine. And what we can do is we can leave the questions until after Angela's session.
Yeah.
So if you have any questions in mind, maybe you can put in the chat, or we can, yeah, we'll wait until Angela's session. But I think it'll be really helpful to see the tool, I think.
Yeah, so this is the DSD tool. Now it's on our electronic patient record system. It's very easy to incorporate in any electronic patient record system. So it was on our care notes and now it's on system 1. So all the codes are already there. It automatically calculates and it automatically gives a RAG rating. It's not a problem. But as you can see, significant life events in last 6 months, unstable, untreated mental health conditions, any unstable, untreated physical health condition, previous hospital admission, significant behavior problems. So it's kind of basic kind of questions it asks, but it gives a weighted score. Any kind of like, because a lot of the time social care issues, residential care, support issues, they also have an impact. So it does pick up on those sort of things as well. So there are few other, like I said, there are 12 variables. Based on the scores, you get green, amber, or red rating. And then on our EPR system, there is actually all the prompts are there in terms of what needs to happen.